Thank you very much. I want to thank the organizers, Jeff, for inviting me here to Colorado. The subtitle, I've been doing a lot of postgraduate education for medical doctors, teaching them in nutrition, and I've faced a lot of how do you say that? Non-accepting low-carb diets with the medical doctors, and talking about non-alcoholic fatty liver disease, I realized that they're much more open. They understand it much better, and it's mainly, especially with the male doctors, because it's a male topic. Guys are afraid of, not having a functional liver. They're afraid they can't continue drinking their beer, and so even when I give public talks about liver disease, as a nutritionist, you're used to having 90% female people in the audience. When I talk about non-alcoholic fatty liver disease, I have 50% guys sitting there, so that's quite interesting. Well, I do have a conflict of interest, which applies only to Europe, to Germany, Switzerland, Austria, because you can't get my books here on this topic, and I have a commercial diet program for treating non-alcoholic fatty liver disease, but you can't get it here either, so I guess I don't have a conflict of interest here. To define what we're talking about, if the wet liver tissue, if the wet liver fat content is more than 5.5%, if alcohol is not the cause, if for females less than 20 grams per day, for males less than 30 grams per day, and if other causes can be excluded, we talk about the non-alcoholic fatty liver disease. I did a PubMed search just a few days ago, and what you can see here is the first hit when you put in NAFLD. The first hit was in 1976, so it's a really very young disease. And in the year 2000, there's 6 hits. There are only 6 publications in the year 2000. And now, when you look to the right side, you can see in 2016, at the end of 2016, we have 1,977 publications, so you can see tremendous interest all of a sudden in this topic. The reason is the prevalence is extremely high. This is a very new publication, came out a few weeks ago, and when you look at publications concerning prevalence, you have to be careful how was the diagnosis done. Most papers used liver enzymes or ultrasound, and they really underestimate the disease. So when you use better devices like MRI or MRS or this new more sophisticated CAP controlled attenuation parameter, you get much higher percentages. So for the US, we can expect about 30 to 40% of the population that has non-alcoholic liver disease today. For everyday screening, we saw some pictures today from ultrasound. Yes, in our program, we tell the doctors, go ahead and use ultrasound, but in addition, use this risk calculator. It's called fatty liver index, and it uses 4 parameters, which you can see on the right. And if you feed this Excel calculator, and you get a result. And if the fatty liver index is above 60, you have a high probability of having fatty liver. If you're below 20, you're very likely not to have fatty liver disease. So here, some some more data. In the general population, 30 to 40%. When you look at obese people, you will have about 60% of the obese. And if you look at type 2 diabetics, you have about 80, 70, 80, 90% of them have fatty liver disease. The German study showed that 30% of school kids, overweight school children, already have non-alcoholic fatty liver disease. So this used to be a disease that hepatologists were interested in because it can advance to NASH and from there to cirrhosis and to liver cancer. But all of a sudden, it's been realized that it's really much more interesting also for cardiologists, for diabetologists. We heard a lot of it this morning, and here's just to show some recent publications. All of a sudden, it's been realized non-alcoholic fatty liver disease is in the center of all our metabolic problems. Another quote from a recent publication, a very, very good review on a topic, and what's realized now is that it's if you have non-alcoholic fatty liver disease, it's an independent risk factor, independent of all other known risk factors for cardiovascular disease. It has been suggested that you can use NAFLD actually in a much more precise way than the criteria for the metabolic syndrome in order to realize if you have a high-risk patient. So how, just in general, how does it develop? It's an imbalance between what comes into the liver and what gets out from the liver. You can either oxidize fat in the liver for ATP, or you can secrete fat with VLDL. As we heard this morning, fat in the liver tries to get rid of the extra fat. So that's one side of the scale. The other side is where does fat originate? You have three sources. One is your adipocytes, one is dietary fat, and the third one is dietary carbohydrates. And in 2005, this really incredible study was done, and they gave the patients with NAFLD, they gave them food that was labeled, and they did infusions with radioactive material, and then they were able to trace exactly where the liver fat comes from. And the surprise, I think, was pretty great that most of the fat in the liver comes from your own fat cells and not from food. So that's a bit absurd. Why don't adipocytes store the fat? Why do they get rid of the fat? And so we have to look at the adipocytes for a second. I think that's very interesting, and then we come back to the question, is it only diet, or is it the combination of diet and lifestyle that's really on the base of everything? So when we overeat, the storage place has to expand, the adipocytes have to expand, and they have a maximum expansion. And when that is reached, the question is, does it still get enough? Do the fat cells still get enough nutrients, still get enough oxygen? So the question becomes very critical. Is there enough angiogenesis happening so that the blood can get to the cell? And one of the critical points is obviously that at some point when they expand maximally, they don't get enough oxygen. So the fat cells get hypoxia, and then they create an inflammation, maybe to increase blood flow, a possible solution. But once they have their inflammation chronically, they lose their ability to store fat, and then fat is being poured out. It's an overflow situation from subcutaneous fatty acids. I mean, from subcutaneous adipocytes. So Schulman published this in the New England Journal of Medicine in 2014, and I think that's a very important paper, which showed very nicely that once you have a defect in adipose fatty acid metabolism, then the fat is being distributed to other, fat has to look for other storage places, and it starts to deliver the fat into other organs, into the muscle, and into the abdominal cavity. So to summarize this, on the basis of everything, obviously, is a dysfunctional adipocytes, and they can't store the fat, lipid overflow, and we have a fantastic storage place in the abdomen. You can fill 4, 5, 6, 8 liters of fat in there. And we saw the pictures this morning. This is a graphic, and you can on the left you can see, we saw the real pictures. You can see it really fills up, and it can even expand. You can fill even more fat in there because the stomach can expand. But what's really important is that this visceral fat maybe is only a marker of what's happening with the organs that are in this cavity, because all of these organs fill up with fat also. The liver, the pancreas, the kidneys, and when this happens, these organs start to have this, they don't function anymore. Coming back for a second to angiogenesis and lifestyle, we now know that this is a really important aspect of this whole development, and we now know that with exercise you can help. You can increase your angiogenesis not only in your muscle but also in the fat cells. So maybe you should teach your patients you have to do sports not only for your heart and for your muscles, but to keep your fat cells in check. Sports to keep your fat cells fit. Okay? New message. So this is how the experts in the field think how this whole metabolic problem is really developing. It's the visceral fat, maybe only as a marker, but the fatty liver as the main metabolic organ, but all the other organs get fat too. And we heard about the pancreas this morning. I think Dr. Fang really nailed it to the point. Fatty liver is really one of the two main reasons why type 2 diabetes develops. Fatty liver becomes insulin resistant. It's not regulated by insulin accordingly. So throughout the night, the liver gives just secretes more and more glucose. People wake up in the morning, although they haven't eaten for 8 hours or 10 hours, they wake up with 110, 120, 140 milligrams blood glucose. The basal insulin doesn't stop the liver from secreting it. So it gets fatter and fatter. It tries to get rid of the fat with VLDL. And there's more fat coming from adipocytes, and then after a while, other organs store ectopic fat, and the pancreas stores fat, ceramides and DAGs, and the pancreas will develop lipotoxicity, and then we have the problem of beta cell dysfunction and so forth. So we have two cycles working together for type 2 diabetes. So now the internal medicine people and the cardiologists are waking up, because it's becoming more and more clear that all these risk factors that we can measure, inflammation and dyslipidemia and thrombosis, blood clotting, and thrombosis risk. All this has to do with liver function, and fatty liver, is not able to function correctly. So this is how it's explained that NAFLD is an independent risk factor for cardiovascular disease, and I think we're going to hear a lot more about this in the future. If you have patients with atherogenic dyslipidemia, high triglycerides, low HDL, small dense LDL, you can see them in lean people, in normal weight people also, and if you see that, you can be sure that, or almost sure that there's a fatty liver behind it. This typical dyslipidemia, and here's a nice quote from a study published last year. It's all about the liver. If you see this, check the liver, look at the liver, and in most of the cases, you will find a fatty liver, even in lean people. I have many doctors have approached me in the past years when they heard me or read my books. They're lean, they do sports, they do exercise, and they check their liver, and they were surprised to see that they have a fatty liver. And when you ask them, what do you eat? Lots of fruit juices and smoothies and so forth. And so more problems that the cardiologists realize is related to NAFLD. So we'll hear more about it. So coming back to the sources of fat in the liver, the second major source is not dietary fat, which is always, what you can read in the textbooks. It's dietary carbohydrate. So how does that work? As we heard this morning from Dr. Fung, it seems to be all about hyperinsulinemia. If you're insulin resistant and if you eat a regular mixed diet, you will have a high insulin level. The higher, the more insulin resistant you are. So as an example, you can see insulin secretion during an oral glucose tolerance test in blue from a well-trained 45-year-old doctor and his patient with metabolic syndrome, not diabetic yet. And he needs, for the same amount of glucose, 75 grams, he needs 5 times, 6 times more insulin to get the glucose out of the blood. So this guy, after 2 hours, had a normal blood glucose count. It was down to 130 or something, normal. But if you don't measure the insulin, you don't know how much it takes to get the glucose out of your blood. So this hyperinsulinemia is the critical aspect, and because this triggers de novo lipogenesis. The mechanism is now clear. It was published in 2014 in this very nice review, which I can only suggest you follow up. Postprandial blood sugar going up plus hyperinsulinemia triggers transcription factors, two transcription factors in the liver and in the fat cell to make fat out of carbohydrates. So this is a problem that really occurs not for everybody, but people with hyperinsulinemia. So carbohydrates are not really a problem for everybody, but they're more and more of a problem in this society, which is getting fatter and fatter and doesn't exercise and doesn't sleep and doesn't get enough sunshine. This this study really opened my eyes in 2003. That's when I became really interested in this topic. From a very famous group in Berkeley, they were comparing 3 groups of people: lean, normal weight, normal insulin with normal insulin, overweight people, normal insulin, and overweight people with hyperinsulinemia. And they placed them on a isocaloric 46% carbohydrate diet, and then they used They use tracers, again, to see exactly what is happening. And isotopes, thank you, isotopes. And then what you can see here is in white, de novo lipogenesis on this carbohydrate diet, 46% carbohydrates, isocaloric. There's basically no de novo lipogenesis. In the second group, obese but normal insulin levels, there's hardly any de novo lipogenesis. But on the same diet, the overweight people with high insulin, they have 4 times more de novo lipogenesis. So on the same kind of diet, people with hyperinsulinemia get fatter inside. When you see this, when you know this, and you advise people to go on a low-fat, high-carb diet, I think it's unethical. You know, I mean, it's very obvious. So you have to really differentiate when you do nutrition advice. Do you have people that are lean, that do lots of exercise? You know, they can burn up their carbohydrates, and they probably won't have a big problem with it. But if you have insulin-resistant people with a high insulin level, postprandial, then they will run into a problem, and there's no way around it. So this is this is very characteristic, this increased de novo lipogenesis in people with non-alcoholic fatty liver disease. So when we consider how can we treat them, of course these people need to go on it's very logical that carbohydrates is a main topic, and you have to lower the carbohydrate intake for sure. Of course, we heard about fructose, a weapon of mass destruction. Yes, fructose is even graver than glucose concerning this topic. I don't want to go into it now. I just want to remind you that we heard this morning. This is how you produce foie gras. You feed them with starch. And we have a German word which I just translated here on this slide. We actually, in old books, how to produce fatty liver, it says you have to noodle. You have to noodle the geese, you know, and nowadays, of course, it's done with force feeding. But if you buy organic fatty liver, without force feeding, the producers will give them overly ripe fruit. So with this fructose, these birds develop a fatty liver by them, without force feeding. So, second part of my talk. First of all, there are still no drugs out there that are, especially made for this treatment. So it's lifestyle still is the main treatment. And then when you look in textbooks, you will always read weight loss is the main thing. So yes, of course, if you go on a low calorie diet, if you are in a negative energy balance, you will burn up your fat, and yes, your liver will get leaner. Fat will get out of your liver. But surprisingly, those many reviews, even just recently published reviews, they don't go into more detail, because there is actually more to it than weight loss, which is I want to show you now. So this is a very new publication from last week. Their treatment is weight loss. That's it. But when you go into the literature, you find there is many more aspects that you can follow and maybe help the patients, be more effective and need less time in order to reach your goal. I want to just show this real quick because I'm going to come back to it later. When you look at the literature, what's the most effective dietary treatment? It's actually meal replacement. It's low, like modified fasting, 600 calories a day, 800 calories a day with liquid meals. Even if you look at 12 months or 20 months, 22 months, it's this meal replacement with formula is the most effective modified fasting, the most effective treatment for weight loss. I want to come back to it with a study. We've heard about the study this morning from Dr. Fung already, and I think this is a very fascinating stuff that these people are doing here in England. The first one that really impressed me so much that I started to look into this topic further and further. They put 11 diabetics on this formula diet. They used 3 meals a day, a very normal, regular, you can buy it everywhere. I think it was Optifast, not a very good quality formula, but anyway, 600 calories per day plus 200 calories of low carbohydrate vegetables. So they came to, it added up to 800 calories per day. So medication, oral anti-diabetics only. They put him on this diet for 8 weeks. So in the first week, they started off with about 100 kilograms, and they lost 4 kilos, which is partly water, partly fat, a little bit of lean mass. But 4 kilos is not very much. But what they did now, every week they were pushed into this MRI machine, and then they could really look at what's happening inside of the body. So when you look to the left on the top, hepatic triglyceride content, they lost with 4 kilos body weight loss, which was 4% body weight loss. They lost 30% of liver fat. Now look down to on the left side. The fatty liver is responsible for secreting so much glucose. So you can see within the first week, with losing the fat in the liver becomes more insulin sensitive, is regulated, and it stops giving out the glucose. First 1 week, okay? Hepatic, on the right side, hepatic glucose production is down, so it really, after the second, third, fourth week, really, there is no more advantage to it. And then we saw this morning already, and I want to show it again because I think it's so fascinating. Then they looked at the fat in the liver, in the pancreas, and supposedly the beta cells, they're gone, they're not functioning anymore. But what they were able to show, when you start early enough, none of these diabetics were diagnosed for longer than 4 years. So they were able to show that with decreasing the fat in the pancreas, you can actually activate the beta cells again. They start working again. After 1 week, there's already a significant sign, and after 8 weeks, it's almost comparable to the healthy control group. And these guys were able to show that this has nothing to do with being overweight. You can see 3 patients from the study. They had type 2 diabetes with the red point. They lost some weight, and they had remission of diabetes, when they reached the blue BMI. They only lost, a little bit, the guy on the right, and he's non-diabetic. BMI, he was diabetic with the BMI 34. He's non-diabetic with BMI 32 or something. The other guy, he had diabetes BMI, 30, 31? He lost some fat. He lost, he had diabetes remission, 29. It wasn't the weight. It wasn't, it has nothing to do with what's on the scale. It has to do something with what's in your organs. He called it a personal fat threshold to reach endocrinologic and metabolic competence again. Decrease the fat out of these organs. So this is formula diet. When we come to real food, there's pretty good evidence that a low-carb ketogenic diet is probably the optimal way to go. First of all, we know when it comes to weight loss per se that there's an advantage here. This famous meta-analysis, I think, pointed it out real precisely, that there is a clear advantage if you stick to it, that the low-carb ketogenic diet is superior to other forms of diet when it comes to weight loss. Considering non-alcoholic fatty liver disease, one of the first studies, or maybe the first study that I saw concerning ketogenic diet was with Eric Westman's group in 2007. It wasn't controlled. It was a small study, a pilot study. It wasn't controlled, but the results were clear. It was very successful in getting rid of the liver fat. The second study, small study, pilot study, 2011, they did a 12-week intervention, 14 obese patients, and they were able to improve liver steatosis significantly. So not a big surprise, no control group though. Therefore, I want to show you, I think, the two major studies, the most important studies on this topic. An American group showed this in 2011 also. Two groups randomized. One group was placed on a low-calorie diet. It was calorie controlled, on average 1,300 calories per day. The other group was on a very low-calorie carbohydrate diet ad libitum. So only the carbs were counted, and the calories were ad libitum. So they actually ate a little bit more. They came to ad libitum to 1,500 calories. And then after the study was over, at the end of the study, the weight loss, which you see here in blue and in green, green for low carb, blue for low fat, the weight loss was similar. The weight change was similar, no significant difference, but hepatic fat content was extremely different. You can see minus 55% with a low-carb diet, although they ate more, they had more calories, versus the 28% on the low-fat diet. Same weight loss, much more liver fat gone with the low-carb diet. So, unfortunately, this study is not really being talked about too much in those reviews. The second study, I think, is very important, from Samuel Klein's group here, very famous researcher here in the United States. They compared two groups, randomized hypocaloric diet, 1,100 kilocalories per day. One was a very low carbohydrate, one was a very low fat diet. And they measured after 2 days, and they measured after 11 weeks. Everybody had to achieve the same kind of weight loss, and then they looked at the liver. So here on the left, you see in black low carb, in white high carb, fat mass, fat-free mass, and intrahepatic triglycerides. And after 48 hours, there's a significant difference. Same kind of calorie reduction, much more liver fat is gone in the low carb group. Then after 11 weeks, 7% weight loss. There's no difference between the liver fat between those two groups. So this study is often quoted in reviews as saying there is no difference. Okay, but now wait for this. Then they looked into the liver a little bit more closer, and they looked at hepatic insulin sensitivity, and there was a highly significant difference between low carb and low fat after 2 days and after 11 weeks. And also important, hepatic glucose secretion, but the morning glucose, a highly significant difference, although you had the same kind of weight loss. So why is the study always quoted as there is no difference between low fat and low carb? Okay, so calorie reduction, of course, is helpful, but also I think is very interesting, because for many people, it's hard to stay on a low-calorie diet. It's hard for them to lose weight. So it should be interesting to see if there's a specific effect with macronutrients, with other kind of nutrients. So I'm going to go through this real quick. All the stuff that I'm showing now is without calorie reduction. Here's a study from Switzerland. All these guys did was advise these women with non-alcoholic fatty liver disease to have a whey protein drink, whey protein. That's all they had to do, 60 grams per day with whey protein, and after 4 weeks, liver fat was decreased by 21% without calorie reduction, without weight reduction. A German study that came out just a few weeks ago, they put people with NAFLD type 2 diabetes from their regular diet onto a high protein diet. One group was animal protein, the other group was plant protein. The hypothesis was that plant protein would outperform the animal protein, you know, this typical nutritionist thinking. And well, they were quite surprised. So the protein came up to 30%, carbohydrate down to 40, 30% fat, and they were quite surprised to see that animal protein worked better. Increase your protein, no weight loss, no calorie reduction, and it was minus 48% on this high animal protein diet. The authors actually expressed their surprise in the publication, so that was good. So another interesting topic, I think, is olive oil, virgin olive oil. I'll show you two studies, an American study and an Italian study. Also, no calorie reduction, no weight reduction, isocaloric. Patients with non-alcoholic fatty liver disease, 6 weeks crossover. So what they did is they reduced carbohydrates and increased fat with virgin olive oil. So after a few weeks, you could see that liver fat was down 39% on a high-fat diet with virgin olive oil. An Italian study showed exactly the same thing, increased the fat intake, reduced carbohydrates moderately, and with this olive oil, they were able to decrease liver fat by almost 30%. So what's happening here? It's not easy to understand. These Italian researchers found that it's mainly an increase in fat oxidation, which is happening here in the liver. And they suggested that polyphenolic substances in the olive oil might have a certain effect. And when you look at the literature, there's actually a very interesting substance in the olive oil, which is called hydroxytyrosol, sorry. And in combination with your gut bacteria, it seems to be turned into a pharmaceutical substance that helps decrease liver liver fat and inflammation and insulin resistance. So that's an interesting topic. Very good studies are out on omega-3 fatty acids. The mechanism of omega-3 fatty acids is quite clear. The minus shows you it blocks the transcription factors for de novo lipogenesis. It increases PPAR alpha, increases fat oxidation in the liver. It increases the bile acid flow, and it downregulates inflammation in your adipose tissue, which is, you know, the bad guy in the whole story. So it's not surprising then when you look at randomized controlled studies using long-chain animal omega-3 fatty acids, you can see a significant effect, lowering of the symptoms, lowering of the markers, and less liver fat after a few weeks, without weight reduction, without calorie reduction. So I don't have the time to go into this. There's a list of other ingredients, I mean, food substances, how do you call them, nutrients or micronutrients that have where there's some evidence. Some of them have real good evidence, some have not as good evidence. But for all of these substances, it has been shown that it helps get fat out of the liver, or increase your liver function, or stop the inflammation in your liver. So this is a really interesting topic, but I don't have the time now to show you the studies for this. What I did, looking at all this literature a few years ago, I thought, okay, there's more than weight loss to this whole story, and I created something that I called liver fasting. It has four basic principles: calorie reduction, carbohydrate reduction, protein increase, and modifying your fat intake, and making sure that these other aspects, nutrient-specific aspects or effects, can be used. So I asked a partner of mine if he could create a formula diet to do an intensive liver fasting, like a modified fasting for 1 or 2 or 3 or 4 weeks, like Rod Taylor did in his study in England. And he produced this for me. And that's what we do now with our liver patients. We put them on a 2-week intense liver fasting diet. As in the English study, 600 kilocalories with 3 liquid meals. And this special substance contains a lot of fiber, high protein, and all these other substances. And then 200 kilocalories extra with vegetables, low starch vegetables. And then we teach the patients to continue afterwards with a low carbohydrate Mediterranean style diet. If they want to, they can go on a ketogenic diet. If they feel that they want to do it, we encourage them to do it. But for most people, they prefer to go on this kind of a Mediterranean type of low carb diet. So for the long run, we tell them, okay, try to keep, to prevent an increase in liver fat, stay on this Mediterranean low carb diet as long as it's possible. If you gain weight, if there's indication that liver fat is increasing again, do a week or do some days of liver fasting in between. So, we offer this to the patient. There's two studies out now that looked at this concept, and it's working very well. They're published in German, so I didn't bring them. German books are out. If someone wants to read German, I'm sure you can get them on Amazon. I want to stop with a pyramid that I created. This is not specific for this therapy. You'll recognize this pyramid, but actually this comes from an idea to have an alternative food pyramid for the broad population, a preventive food pyramid, and I called it Flexi-CARB-PYRAMID because I wanted to show the people for prevention that carbohydrates per se are not the big problem if you do enough exercise. So on the right side you see those sneakers and the weights, meaning that if you have to earn your carbohydrates, okay? You have to earn your carbohydrates and if you don't do that, you have to stay away from them. Because your lifestyle nowadays is not enough exercise, not enough sleep, not enough sun. So that I included these. You can see the sun, and you can see the sleep, and you can see olive oil and butter as the main fat sources, and 1 or 2 glasses of wine, of course. And so with this, I want to end, and thank you very much for.